Kia ora tātou, everybody. Bruce Harrell's my name. I'm the director of the Goodfellow unit. And it's a great pleasure for me to introduce Dr. Hari Talreja. He's a physician at Middlemore Hospital, and he has a special expertise in hypertension. So, Hari, over to you. You've got 40 minutes, sir.
Thank you very much, Professor Harrell, for inviting me to talk about difficult to control hypertension, which is also known as resistant hypertension. And kia ora, everyone. So let's get started. These are my credentials very quickly. I practice in public at Counties Manukau and also got attachments in private at a few centers. I'm soon going to start at Medical Specialist Center in Epsom. Nothing to disclose. So let's get started by one of the cases that Professor has referred to me just last week. And unfortunately, I haven't been able to see her because the clinics are shut down due to the lockdown period. She is a 85-year-old lady who's fairly functional and has a long-standing history of hypertension. She's got some of the comorbidities as I've listed here. This is her antihypertensive regimen. So as you can see, she's on 7 different antihypertensive medications. I've got some of the information from Clinical Portal that shows that her BMI was 23.7. That means she's not obese. 2 years ago, her blood pressure was not too bad. It was 140/80 recorded in one of the clinical letters, and she was on lesser antihypertensive medications. I've got these investigations available on the system. She has normal renal function. The serum potassium is in target range. Plasma metanephrines were normal. And she has a previous scan which shows normal adrenals and normal sized kidneys, but a few cysts in the kidneys, which is probably related to her age. So how do I go about dealing with this patient? Before we jump ahead, I just wanted you to familiarize with some of the terminologies that we use in the world of hypertension. So the most common one is apparent resistant hypertension, which is simply put, the patient has been prescribed 3 antihypertensive medications and the blood pressure noted is not at target. So that's that's apparent resistant hypertension, which basically gets divided into the true resistant, which are actually treatment resistant hypertension, and the other ones are the false positives, which are pseudo-resistant hypertension, essentially meaning the patient may not be taking the pills you prescribe. And then there is this refractory hypertension, which is basically use of 5 or more antihypertensive medications. So our lady here, she's on 7 medications, and she fits the category of refractory hypertension. So how common is resistant hypertension? Generally, it's believed that 1 in 10 or 1 in 8 patients will have resistant hypertension, but the incidence and prevalence vary depending on the population you are studying. What are the risk factors? Some of the common risk factors include suboptimal therapy. That means the patient has been prescribed antihypertensive therapy, but the doses are not at optimal range. And the other factors including poor lifestyle choices leading to obesity, which is very common in the South Auckland population that I see at Manukau. Some of the medications can interfere with blood pressure control. And there is this theory that patients do have increase in the extracellular volume, which may not be apparent clinically. And obviously, we are familiar with some of the secondary causes which can lead to resistant hypertension. So how would I go about dealing with this case? So I simply follow 7 steps, which I'm going to show you now. Here are these. And I go stepwise so that I don't miss out on any important factor. So let's go through these 7 steps together. So the first 2 would be confirm that the patient has treatment resistance. And the second bit is making sure that this is not a false positive increase in blood pressure. So how do I confirm that there is treatment resistance? Basically, it has to fit the definition, which essentially is the blood pressure is not at target despite use of 3 or more antihypertensive medications. Or the blood pressure may be at goal, but the patient needs 4 or more antihypertensive medications. So our lady fits this definition, right? Now we need to make sure this is not falsely elevated. So I do 4 things for that. I make sure that the blood pressure technique is appropriate. That means the patient is sitting quietly in the chair with a back which is supported for at least 5 minutes. What we are interested in is in resting blood pressure, not a casual blood pressure, which quite often we see patients just walk into the clinic and the blood pressure is checked, which is a casual blood pressure. We make sure that we got a few readings, not just one, and the patient has not had coffee or hasn't had tobacco half an hour prior to the measurements, because that can give you falsely elevated readings. So the second thing which I'll look is making sure that the size of the cuff that we've used is appropriate. That means the bladder should encircle at least 80% of the patient's arm. If that's not the case, the blood pressure would be falsely elevated. The third thing which I look at is whether the patient is actually taking the medications. So we've been prescribing medications, but the patient has not been taking. Maybe because the patient has developed side effects. Maybe we are giving too frequent doses. That means if you give somebody 3 times a day dose of blood pressure pill, they may not take it. I probably won't take it. We also have to look at the cost factors. Are we kind of making sure that there's no issues with the cost? Therefore, we sometimes involve pharmacy and also the family members to look into all these factors. The fourth thing, which is we all know, but we overlook many times, is something called as white coat hypertension, which essentially means the blood pressure at home is fine, but when they come to the clinic to see you, the blood pressure goes up. And it's not uncommon. The reported incidence varies from 20 to 30%. So 1 in 4 at least will have this kind of hypertension. And the way we figure out is the patient's blood pressure is high, we give them the medications, they go home, they feel dizzy. Or they've been hypertensive for a very long time, but there's no end organ damage. And that's when we start suspecting. And therefore, we encourage home blood pressure monitoring. Or if we have access to ABPM, then we go for ABPM. So once we've done these 4 things, we've essentially ruled out the false positives, and we are left with what we suspect as treatment risk. Right now, the next 2 steps would be identifying and reversing the factors which are modifiable, and then discontinuing the interfering medications which could increase the blood pressure. So the modifiable factors, lifestyle and diet, multiple interventions. We many times underestimate the importance of these because if you look at all these interventions, salt restriction is the key. Weight loss, especially obesity, is the biggest risk factor for hypertension in the patient population I deal with. Moderation of alcohol, regular exercise, and very important, I do recommend DASH diet, which is basically a dietary approach to stop hypertension. Now, if you add up all these interventions, if somebody is doing, it can give you a benefit of 15 to 20 millimeters of mercury systolic, which is almost 1.5 to 2 pills less for the patients. Hence, lifestyle and diet should be advocated for everybody. Next, we look at the medications which can interfere with the blood pressure medications. So not uncommonly, we see patients going to the pharmacy and picking up the non-steroidal anti-inflammatories, and they can actually increase the blood pressure or reduce the effect of the antihypertensive medications. Nasal decongestions, we've got other medications such as cyclosporin, erythropoietin, especially in advanced CKD patients. We've also got some antidepressants which can cause an increase in the blood pressure. So we need to make sure that these are discontinued if possible. So once you've done these 4 steps, now we are dealing with someone who has truly resistant or treatment resistant hypertension. So we have to have index of suspicion for secondary causes. So let's look at what are the secondary causes. So very briefly, the first 4 or 5 causes that I've listed here are the common ones. Chronic kidney disease, one of the important ones which we overlook many times. But this is easily detected because you can do just 3 simple tests: serum creatinine, do a midstream urine sample to see for active sediment, or if there is presence of proteinuria, you do a morning urine albumin to creatinine ratio. That should pick it up. Aldosteronism has been reported for anywhere from 1 to 15% depending on the population and the setting. So if we see in tertiary care setting, specialty clinics, you pick these more commonly. Simple test, plasma aldosterone to renin ratio. Make sure that's done early in the morning at 8 o'clock to make it more reliable. And that should be a screening test for primary aldosteronism. The other thing, renal artery stenosis, we need renal imaging. So these are the modalities that I've mentioned. And depending on the setting, we need to pick which is the more appropriate modality for diagnosis of renal artery stenosis. This can happen in older and younger individuals. So older atherosclerotic renal artery stenosis is more common. In the younger one, fibromuscular dysplasia is more common. Obstructive sleep apnea, again, one of the most common causes of hypertension in my patient population, fairly commonly missed. We can inquire about daytime somnolence. We can inquire from the partner if the patient has been snoring very loudly. A simple screening test is Epworth Sleepiness Scale score, which I ask them to fill up every time they come and see me. And that should give us a fair sense whether the patient has significant obstructive sleep apnea to contribute to resistant hypertension. The other ones are not very common, but in the specialty clinics, we have to make sure that we rule these out. These include pheochromocytoma. A simple screening test would be plasma metanephrine. Cushing's syndrome, 24-hour urine cortisol is a useful test. Hyperthyroidism or hypothyroidism, so we can do a thyroid function test. Hyperparathyroidism, especially the primary one, again, PTH level could be done. And coarctation, which is highly uncommon, we need echo and further cardiac imaging. When I order some of the tests, I also kind of try and get a baseline ECG to see if there is presence of LVH, because ECG is very simple to do. And it will tell us whether the hypertension has done the damage. So once we are done with that, then the next part is how do we approach these patients in terms of their pharmacological treatment. So I won't go into the details of each and every class of antihypertensives. I'm sure we are all familiar with that. But I generally use a few treatment principles in a couple of classes of medications, which I will talk about. So the principles that I use is obviously I'll try and maximize adherence. I think if I'm not going to take it, the patient may not take it. So I need the least number of pills, which means I end up using the longer actings and preferably once daily dosing of medications. I do acknowledge that many times this is not possible, but this should be a goal. I'll try and use different class of antihypertensive medications so that I'm not using the maximum doses, which means less side effects from each class. I do encourage home blood pressure monitoring, which is basically inviting the patient to participate in his own care. And then there are some multidisciplinary approaches which involve dietitians and pharmacists, etc. So the two main classes that I use, these are my secret weapons, or not so secret actually. One of them is the diuretics. Now, these are the mainstay. So if you remember, the definition of resistant hypertension also has the criteria of having a diuretic as one of the three antihypertensive medications. This is a mainstay because there's evidence about occult fluid overload, which is not obvious when you do the clinical exam. And this was shown by increase in the level of ANP and BNP. So diuretics should be used. Use a longer acting one. My favorite is chlorthalidone, which is a good old school pill, but as one of my favorites. Many societies will tell you to maximize diuretics. Still, the patient experiences adverse effects, such as hyponatremia or hypokalemia, or increase in creatinine, or the goal blood pressure has been reached. Now, bear in mind, if there is chronic kidney disease and the GFR is less than 30, the thiazide group of diuretics may not work that well. So we need to change such patients to loop diuretics, such as furosemide. Then there is the second class of antihypertensives, the aldosterone antagonist. More commonly, what we have here in New Zealand is spironolactone. The other option is amiloride, which is weaker. But spironolactone is really a very good add-on antihypertensive, and there are heaps of studies, including ASCOT trial, which will tell you how effective they are. The recent one was this Pathway 2 study I've just put in this slide, just to give you a sense of how effective it is as compared to the other classes. So here is spironolactone. You can see the home blood pressure is really low with this. Now, this is compared to doxazosin or bisoprolol. You can see the effects spironolactone actually kind of is the most potent in this study. There are heaps of other studies kind of showing that spironolactone really works well. Though we need to kind of keep in mind the adverse effects of spironolactone, especially in advanced CKD, where it can cause hyperkalemia. Some men and women can experience gynecomastia, irregular menses, decreased libido, etc. But if you use it at smaller doses, the adverse effects are not very common. So let's go back to our case. Remember the 85-year-old lady who's on 7 antihypertensive medications. I haven't seen her, but I've already kind of got some thoughts in my head. How would I approach her? So again, referring back to the 7 steps, I'll try and confirm treatment resistance and exclude pseudo-resistance. So I'll make sure that she's taking her medications regularly. That means she's adherent. Now, I want to exclude pseudo-resistance, which is common in resistant hypertension, especially if the patient is on 7 antihypertensive medications. So I would get an ABPM to rule out the white coat effect, and also to review the blood pressure load, which is the overall blood pressure, which is above the target. Now, because she's 85, there is also this concern of pseudo-hypertension, which is basically the arteries are too stiff. They're very calcified, so they do not compress when the blood pressure monitor is applied. That could result in falsely high readings. There's something called Osler's maneuver, which is not very specific, but that is one of the thoughts that I have in my mind, that whether this is falsely high and this is pseudo-hypertension. Then obviously I'll look at the lifestyle factors and discontinue interfering substances. So salt intake is what I'm going to look at. The 24-hour urine sodium is a very good test to get a sense of the sodium intake. Because she's 85, I wonder whether she's got some joint issues and she's probably taking over-the-counter non-steroidal anti-inflammatories. Then in my head, I'm thinking about, this is refractory hypertension. What if the salt restriction is fine? She's not taking any other interfering medications. So I'm going through the list of secondary causes in my head. She's got normal renal function, so primary renal disease is out. She's got plasma metanephrin, which is normal, so pheochromocytoma is out. Drug-induced, probably looked into non-steroidals. Coarctation is very uncommon. So from the rest, I will look at the sleep history and figure out if she's got underlying sleep apnea. Though mind you, if the BMI is normal, doesn't mean that this is completely ruled out. We can sometimes see normal BMI patients, but men are more likely to have sleep apnea as compared to women. More common thing, or the most probable diagnosis in my head, is probably she's got renovascular disease. So I need to check if she's got any peripheral vascular disease, poor peripheral pulses, etc. And then there is hyperaldosteronism, for which she's on spironolactone, and I might consider increasing the dose of spironolactone if she's able to tolerate that. Some of the endocrine causes could be contributory, so a very simple screening test, I could do that. Now, in terms of medications, so pharmacologic treatment, I've just put the doses here so you can clearly see what she's on right now. And I'll try and rationalize some of the diuretics. So when somebody's on 7 antihypertensives, some of the medications are not really working. She's on 3 diuretics. So I will probably take off the hydrochlorothiazide, because it belongs to the same thiazide diuretic class, and try and see if I can increase the dose of chlorthalidone/spironolactone if she's able to tolerate that. Otherwise, I've still got some room to increase amlodipine, metoprolol CR, or doxazosin. At the end of the day, blood pressure control is more important than the choice of medications. And as I mentioned earlier, I'll consider screening for renal artery stenosis if this is truly resistant hypertension. Very quickly, another case which I'd seen not so long ago, a 57-year-old male who's really a high-flying person. He's got a long-standing history of hypertension and diabetes, but importantly, no end organ damage, which is good for him. He presented with somatic symptoms, including fatigue and dry mouth. He's got history of nasal polyposis and sinusitis in the past. This is his antihypertensive cocktail. So he's on 1, 2, 3, 4, 5 medications. Not all the medications are at maximum doses, but this is his regimen. He's got family history in both his parents of hypertension. He's got a bit of obesity. His resting blood pressure checked twice, and in both the arms was still elevated. There was a urine dipstick which was done at the referring doctors, and that was unremarkable. And I've got some of the tests which shows normal renal function, normal potassium, and normal thyroid function test. Okay, I go back to my 7 steps and see what I need to do. Again, make sure that I'm dealing with truly resistant hypertension. So check all these 3-4 parameters which we spoke earlier about. I might subject him to home blood pressure monitor. Then, because he's obese, which is one of the important risk factors, I will reinforce lifestyle modification, increasing physical activity, and ask him to restrict his salt intake. He's got nasal polyposis, so I wonder whether he's using those nasal spray or nasal drops which contain pseudoephedrine or oxymetazoline, both of which can increase the blood pressure. And he presented with dry mouth and feeling fatigue, so I wonder whether he's got underlying obstructive sleep apnea. So I'll screen him with the Epworth Sleepiness Scale score and inquire about daytime somnolence, etc. And if need, I'll subject him to overnight oximetry. These are his medications, so we got some room to play with in terms of getting his blood pressure under control. So the first change, this is what I will do, is get rid of hydrochlorothiazide, which is shorter acting diuretic, and replace it with chlorthalidone. I have room to increase amlodipine as well as metoprolol CR. And as a 4th line, I can obviously consider spironolactone for him if need be. The thing which I would like to get rid of is clonidine, because that can also give you dry mouth and a bit of fatigue and sleepiness. But with clonidine, especially at high doses, we need to be careful because there's something called as clonidine withdrawal. You can have a rebound hypertension, but generally at low dose, you may not experience, patients may not experience that.
Hari, we're getting quite a few questions, and I was wondering whether you'd mind if I asked you a few at this point.
Sure, we are almost to the end of these slides here, but I'm happy to take questions straight away.
Okay. So one of the questions was, when should we exclude secondary causes of hypertension after we have difficulties lowering blood pressure or from the beginning?
I think one of the clues that there is secondary cause would include a refractory or resistant hypertension, which means you have to treat them first, and then you can think about it. Age is a good parameter to kind of also help you kind of give clues to whether the patient has secondary causes. So if the patient is young, less than 40 or even less than 30 for that matter, then the incidence of secondary hypertension is quite high. If the patient is older, so roughly, let's say the previous gentleman was 57, so roughly half of the world's population at 57 would be hypertensive because of primary etiology. So in that case, you're not very keen to start investigating, otherwise you'll end up investigating almost everybody. So age, there are certain other clues, which means if somebody has got, let's say, flash pulmonary edema, acute hypertension, where suddenly the blood pressure is quite high, or labile hypertension presenting with palpitations, flushing of the face. These are some of the clues that this will be a secondary hypertension. But to give a simple answer, I would bank on the age first, and then if it's treatment resistant, then I will screen.
Okay. Another question here. Do you prefer urinary ACR to serum ACR? I think you were talking about the serum aldosterone to renin ratio. Is that, or is there a, have I got that wrong?
Yeah, no, so you're right. The serum test, you can't do a serum ACR. It's not very helpful. The test of what I was referring to was aldosterone to renin ratio, which is a morning sample. And that's essentially a screening test for primary aldosteronism. Having said that, many times there are confounders, so you need to get rid of ACE inhibitors, spironolactone, diuretics, beta blockers before you can rely on the test, because there are many medications that can interfere. So it's a screening test that we should be familiar with, but we need to factor in that the medications can interfere.
One of the things I've noticed with our medical students is they don't palpate the radial artery when they're checking the blood pressure. And I had one student one day get a 120/80 when in fact the blood pressure was 160/80, and that's known as the auscultatory gap. I just wonder if you'd like to make a comment. The other thing I do, if I'm unsure about what I'm hearing, I check it with an electronic machine because I'm never, sometimes, it's very, sometimes you're not sure what you're hearing with the Korotov sounds. So any comment on that?
So absolutely, the basic teachings of blood pressure management will always tell you to kind of use the palpatory method. And the technique that we should be using is we should increase the blood pressure. So once you have got the palpatory way of measuring the systolic, then you have to go 20 to 30 millimeters higher, and then you slow down at the rate of almost 5 millimeters of mercury every 2 seconds, generally speaking. So it has to be really a slow drop so that we don't miss out on that. There's no substitution to palpatory method. In fact, Bruce, I remember when I was starting my hypertension fellowship in Canada, the nurse practitioner on day one asked me to demonstrate how do I measure blood pressure. And she was quite happy that I did the right way by palpating first and then double checking with the stethoscope. This is also relevant to your case, Bruce, the 85-year-old lady, if she has stiff vessels. Now, the AOBPM, which is the regular electronic monitor, that tends to circumvent this problem to a certain extent. So that's more reliable because it automatically kind of increases the starting level to 30 to 40 millimeters higher than what the patient's systolic blood pressure is. So I think that's more reliable in that sense.
So what machine is that you're talking about? I haven't heard of that before.
So it's the AOBPM, which is basically a more complicated version of saying electronic monitors.
Oh, okay. Okay. Somebody asked about the diuretic you recommended. Your voice went fuzzy, and I sent a message out saying it's called chlorthalidone. The trade name is Hygrotin. It's been around for 50 years and it's fully funded. And Hari and I are both big fans of it. So about 7% of New Zealand diuretics are chlorthalidone, but it is growing. And I know your unit is very keen on it, Hari, at Middlemore.
That's correct. No, absolutely. It's almost milligram per milligram. It's almost twice as potent as hydrochlorothiazide. And in part, that's due to its longer effect. So if you want a drug which covers you for 24 hours, then chlorthalidone it is.
Yeah. I got a question here. What is the best ACE inhibitor to use now there's a shortage of cilazapril? And I think it's worth reminding people that the ARBs are now funded in New Zealand also. Don't get the cough.
Absolutely. So when I came to New Zealand, we had this criteria that if you have any adverse effect, such as cough to ACE inhibitor, then you can use ARB, which has gone away for a couple of years. In Canada, we used ARBs very, very commonly. So I'm not shy of starting somebody directly on ARB because the evidence is almost similar to ACE inhibitor. In terms of choice of ACE inhibitor, perindopril is my favorite, just because I've used it a lot more often. Cilazapril, as you've highlighted, Bruce, that it's probably going to go off the market, and there's already, I think it's a single vendor supply or something like that. And so perindopril is a good alternative. Otherwise, I go straight for candesartan, which is again one of my favorite. But all the ARBs are fairly similar.
Yeah, and I think perindopril is the longest ACE we've got in the country, isn't it? Longest acting ACE inhibitor. Is that correct?
That's correct. It's a single daily dose medication, so I like those medications generally.
Is it okay to use spironolactone as well as a diuretic?
Absolutely. So, Bruce, your case, the 85-year-old lady was on chlorthalidone as well as spironolactone. We just have to be careful because these both are diuretics. So the risk of hyponatremia, especially in the elderly, is to be watched for. And obviously, being two diuretics, you're getting a lot of natriuresis, which is loss of sodium, and that can make people prone for being pre-renal or volume depleted. So if you're monitoring that, as is the case with all your patient, I think it's fine. At the end of the day, the blood pressure control is more important.
Yep. Somebody here asked about Osler's maneuver. When would we use it, and what does it involve doing?
So it's an old school technique, not very reliable. There are studies which will tell you that it's not very specific. So the maneuver basically involves you're tying the blood pressure cuff, you're increasing the pressure till the patient's pulses are essentially blocked, and then try and feel the pulseless artery. So if you're able to feel the pulseless artery, which is not collapsing, which is very stiff, calcified, then it's supposed to be test positive. So it's a very crude way to figure out if the patient has really stiff arteries, and the intra-arterial blood pressure therefore may not be a truly reflected by a sphygmomanometer. There are other methods which sometimes people have used, which is more based on Doppler. So it's a modification of the older technique. Now, what the Doppler does is do the same principle, obliterate the artery, look distally if there is flow or no, and many times if the artery is stiff, then you essentially can see the flow despite you not hearing the Korotkov sounds, and then you increase the pressure further, and that extra pressure that you have to apply will be the true reflection of blood pressure. So different methods, not very commonly used, but just we have to bear in mind that these could be some of the things that we need to consider.
Okay, question here. What would the target BP for the First Lady, the 85-year-old? I'm aware that her absolute risk of a CVD event is very high if that's a true blood pressure. And she's a very fit and active lady, and I'm terrified she's going to have a stroke, but I'm running out of options, hence my referral to you, Hari. So what would you happily live with her with the blood pressure?
So I'll go by the SPRINT data. She's not a diabetic. SPRINT had excluded diabetics, and SPRINT definitely showed some cardiovascular benefit in patients who are elderly. So my target would be less than 30 or 80 if she's able to tolerate that without any postural symptoms. Now, this is a very common question, and I think, Bruce, I'm working with Wiki to come up with a MET case on hypertension in the elderly, the target especially. In that, we just have to bear in mind if somebody is really frail, because there's this French study which showed really frail people do not do that well if the blood pressure is too low. So if she's high functional, she's able to tolerate the blood pressure under 130 or 80, that'll be my target for her.
Okay. Question here, what do you think about the patient being on both hydrochlorothiazide and chlorthalidone? It's something that I use occasionally in these difficult hypertensive patients, because I find I do get quite a benefit, whether it's just the chlorthalidone and the ACE, or whether it's the ACE, the hydrochlorothiazide and the chlorthalidone. I don't know. What would be your answer to that, Hari?
I think it's, to me, with due respect, it's more a sign of desperation that we are struggling to control the patient's blood pressure despite being on so many medications. I would, when I say in the treatment plan that I would rationalize the antihypertensives, mainly the diuretics, I would definitely take her off the hydrochlorothiazide. I might increase the chlorthalidone if she's able to tolerate that very, very carefully. So generally, I don't use two drugs from the same class. There's another common question which comes to mind, which was asked to me very recently by someone. What would be your combination drug choice? So in somebody like her, my combination preferred combination would be a calcium channel blocker with an ACE inhibitor based on the accomplished trial, and then there will be add-on drugs such as diuretics, etc. So to answer the gentleman's question, I will not use hydrochlorothiazide. I'll just increase chlorothalidone and watch her very closely.
Okay. Which arm should we be taking the blood pressure on? Does it matter? Sometimes there is a difference.
Absolutely. So generally, you would measure the blood pressure on both the arms. So this is what I do in the hypertension clinic. I get generally about 6 to 8 readings because it's a specialized clinic, so I do have extra time. I'm sure that's a challenge in primary care setting.
Yep.
But So I generally would advocate checking on both the sides, especially in cases where it's we have suspicion that the patient's blood pressure is not coming under control despite optimal medications, or if the patient is experiencing postural symptoms with slightest changes in medications. That's the time if you need to definitely look into both the arms, because you do get differences in the arm pressures.
Okay. Limited access to ABPM in primary care. What are the alternatives? I sometimes just get people doing a series of electronic measurements at home over a week.
That's probably the best way to go forward. Home blood pressure, the biggest advantage is it's cheap. It gets the patient involved in their own care. So there's some studies which will tell you that if you do that, then the adherence to medications improves. But I do acknowledge that ABPMs, because just the machines are so expensive. In fact, just to tell you, when I started the hypertension clinic at Middlemore, for the first 6 to 8 months, I did not have ABPM because we do not have enough funding. And finally, we ended up buying 3 machines worth $100 each of automated blood pressure monitors. And I used to give away the patients to take it at home and then maintain a logbook and bring it to me next time. So home blood pressure monitor is a good alternative.
The question of changing dosing from morning to evening, with this lady, we actually did switch her over. I gave her half of pills in the morning and half in the evening, and it did make a difference initially, but not in the longer term. So I wonder if you'd like to make a comment about that. We've got a few more questions after that, and we're running short of time, Hari. So if you could move quickly on these, that would be good.
Sure. So very quickly, there's no harm in splitting into 2 doses if the patient is going to take it. The studies that we're referring to were flawed. They showed too much improvement in the cardiovascular outcomes. So I won't bank on the research behind that, but I think it's a very simple way to addressing the poorly controlled blood pressure, to split the doses into morning and take some at night, covers you for 24 hours. And physiologically, there is increase in sympathetic surge early in the morning, so physiologically it fits into the pattern. So yes, if possible, do it.
Hypertension with incidental finding of adrenal tumor 1 centimeter. Do you investigate for FEO?
This will need another webinar on that, basically.
I guess it's easy to check for FEO.
So depending on the age of the patient. Absolutely. So you can do a simple plasma meta-interference test, but the context is important. You can ask for the symptoms of FEO. Bear in mind, I'm talking about now primary aldosteronism because the study comes from that. In one of the studies, they showed up to 20% of the patients who had this adrenal lesion on their adrenals on a CT scan were falsely positive. So what we call as incidentalomas, actually, and they would have been subject to surgery based just on the anatomical lesion rather than. So we need to make sure it's functional, and a simple plasma meta-interference would tell you whether it's functional or not. Yep.
Last question here. Should we be using chlorthalidone instead of bendroflumethiazide, which is bendrofluozide in New Zealand, earlier in treatment for non-resistant hypertension? What would be your advice?
It's a matter of choice. So my answer would be yes. I like you, Bruce. I like chlorthalidone. I've got good results with chlorthalidone. So I don't use other bendrafluosides rather than my preference is chlorthalidone. So if you ask me my personal choice, yes, please go for it.
Okay. If white coat hypertension is suspected, do you stop their antihypertension medications for the test?
No, actually, I want them to be on stable regimen because there are two things. One is white coat hypertension, which means the blood pressure at home is normal, so the patient doesn't need treatment. The other bit is white coat effect, which means the blood pressure is it's exaggerated in the clinic. So I would keep them on the same stable dose and then subject them to an ABPM or a home blood pressure monitor to see the effect.
Question about recommended daily urinary sodium level to aim for. That's presumably doing a 24-hour or an overnight urine?
Yeah, so 24-hour or time collection, sometimes you can do 12 hours as well, but 24 hours if the patient can do it. I am not happy if the urine sodium is more than 200. Closer to 100 is probably not too bad.
The average New Zealand one is about 150 millimoles a day. So, and people don't like sodium restriction. It was one of my PhD topics.
Bruce, my first patient in the hypertension clinic, I was talking about salt and dietary interventions, and the patient said, "Doc, you talk to me about anything and everything, but don't tell me anything about my salt. I love my salt."
Exercise, yes, sodium restriction is tough. What do you think of automatic machines? I've found significant problems with them in my office compared to manual. Can you comment?
Sorry, the automated blood pressure machines?
Yeah, this doctor is having trouble with them in his office. I guess you get funny measurements. That's what I find sometimes. The machine doesn't go. Any comments on using them? I guess the validity of the answers.
Yeah, so I mean, you have to bear in mind that these needs recalibration from time to time. They lose their accuracy within 6 to 12 months. Many machines, sometimes you can have good machines lasting for 3 to 5 years, but as time goes by, you need to recalibrate with the sphygmomanometer reading for that. And at the end of the day, these are machines. At Counties, we are new machines, automated instruments, and our engineering department figured out the brand new machines was overestimating by 10 millimeters of mercury. But it's convenient, it's cheap, it involves the patient, so yes, use it, but just bear in mind they will not be as accurate as time goes by.
A nice question here about edema from CCBs, which I think is a real big problem. What do you use as a third agent after an ACE-ARB diuretic and they get edema to CCB? Would you go to a beta blocker or an alpha blocker?
Or even spironolactone. So beta blocker, preferably. Alpha blocker, I keep it as a reserve just based on the ALL-HAT trial. So ALL-HAT trial had 4 arms, and one of them was doxazosin, and they had to stop the doxazosin arm early because of increased incidence of heart failure. So alpha blocker in heart failure settings, or because of this risk, I keep it reserved. I go for the beta blocker first. And spironolactone, yeah, I mean, that's one of my favorites, as I said earlier. Low dose 12.5 milligrams of spironolactone can do a lot more good without too many side effects.
Yeah, no, I've had great experience with it. I was a bit disappointed in the 85-year-old lady that it didn't work. Okay, so there's a comment about licorice. My understanding is you have to eat 100 grams of licorice a day to affect your high blood pressure. The odd little bit of licorice isn't a problem as somebody with a smaller licorice addiction.
Yeah, so I mean, you're right. I mean, especially if it's taken in higher quantities, it could be a lot more problematic than smaller quantities. To be honest, I haven't come across very many patients where this has been a major problem, just because the consumption is on and off once in a while. So it's probably at higher doses that it's a big problem.
Right. So we've hit 10:25 now, Hari. So we're going to have to stop the webinar. I would just like to thank you for a fantastic presentation. Thank you very
Thank you
much.
so much for having me.